Welcome to the Better Birth podcast. I am very honoured to have my lovely friend Shellie on today. Shellie has been on the podcast before, and I'm hoping to have her on many times after this. But I'm really, really excited to talk about our topic that we're going to cover today, because I've been dying to do an episode on this. And I know Shellie is very knowledgeable on the topic. So we're going to be talking about gestational diabetes today. Before we dive into this very meaty subject, do you want to introduce yourself to anyone that doesn't know who you are, Shellie?
Hi everyone, my name's Shellie. I am the Serenity Doula. You can find me on Instagram, and also my website is theserenitydoula.co.uk. That's where you can find me online. I have been birth keeper, doula, support person, medical advocate. Well, I've been a medical advocate a lot longer, but doula and things like that for around about 20 years now. So I've seen a lot of birth in a lot of different settings and supported a lot of people. I think what is also important to note is that I studied osteopathic and naturopathic medicine. So I have a background in nutrition and holistic health and healing modalities for the body. So I really understand about what you can do to help prevent disorders in a natural way, which can work alongside medication or separate to medication, depending on how you feel you want to support your health. Yeah.
Thank you, Shellie. And I'm so glad that you've agreed to come on and talk about gestational diabetes, because I have been, like I said, dying to cover this topic, because it is increasingly common for somebody to be tested for gestational diabetes in pregnancy and be told that they have it. So before we dive into talking about gestational diabetes, do you just want to talk about what diabetes is in pregnancy? Because before we started recording, we were saying that actually there's lots of different types and people might not really understand the differences between them.
Yeah. So diabetes really is when the body is struggling for some reason to process the sugar that we're eating, which is coming into the bloodstream. And you end up with sugar in the bloodstream for longer than the body can cope with. And that high levels of sugar in the blood can cause damage to cells, to tissues in the body. And so really we want to keep those blood sugar levels under control. And there are different kinds of diabetes, and it's important to know that there are different kinds, because sometimes it's kind of forgotten in research terms. And also it seems like medical professionals may be a little bit confused sometimes about the different types, because the different types actually have different effects in pregnancy. And so when you're looking at outcomes in studies, if they're grouping all of the types together, it's unfair to do so, because the outcomes are actually different with different types. So there's type 1 diabetes, which actually is an autoimmune disease, and it's often diagnosed early in childhood. And with this autoimmune disorder, basically the pancreas is unable to produce insulin. So basically when we eat something, whatever food, whether it's protein, carbohydrates, fats, the molecules are broken down through the digestive tract from our mouth and all the way through. And sugars are, like carbohydrates, are broken down into sugars, glucose molecules, which are absorbed very rapidly into the bloodstream. So they spike the blood sugar very quickly. It takes longer to break down proteins and fats, and also fiber kind of slows down the absorption and the processing of things. So when we have simple sugars, they come into the bloodstream very quickly. Then in a response to this raise in blood sugar, what happens is the pancreas is then triggered to release insulin. And insulin is a bit like a doorman. So you've got this bloodstream that is the street outside the house. You've got the doorman, and the doorman lets the glucose in to the stores. So primarily we store glucose in the liver and in the muscles. And that provides energy. So it's providing energy for our liver and muscles to work. And then when those stores are full and that glucose is converted into glycogen and stored there, what happens, it is then converted into fat. So we then put on fatty tissue in the body to store that energy for a time when we don't have enough energy, that it can then be reversed, the process reversed, and it broken back down for our body to be able to use it for fuel. So in the autoimmune type, the pancreas cannot produce insulin, sometimes no insulin at all. So people with type 1 diabetes usually have to have insulin in order to get that blood sugar lowered down and get the sugar where it's needed in the liver, in the muscles, or converted into fatty tissue in the body. And that people will have that before pregnancy. People actually nowadays are being diagnosed with type 1 diabetes later in life because we have a lot more autoimmune conditions happening now. So people can develop it later than they used to in the past. Then there are other types of diabetes. So you can have diabetes secondary to other conditions. So, for example, with cystic fibrosis, because the pancreas is very gunked up because of the way that the calcium and sodium channels work in the cells, you can then get malfunctioning of the pancreas happening. And then we have type 2 diabetes. So with type 2 diabetes, you may have it before you're pregnant, okay, or you may develop it during your pregnancy, okay. But if your blood sugar levels are under control, it's fine. If you are struggling to control your blood sugars, then it can have effects on the pregnancy. And the effects that can cause really the most issues in terms of loss of life of a baby or malformation of the baby are when the blood sugar levels are not controlled very early in the pregnancy. So in the first 8 to 10 weeks of intrauterine life, we have the process called organogenesis happening. So that's where the organs are being formed in the baby, and it's very sensitive to homeostatic balance levels in the body. So if you have high blood sugar levels, it can cause malformations of the fetus, and it can cause miscarriage. So if that's only if the blood sugar levels are high early in pregnancy. Okay, so that's with type 1 diabetes or type 2 diabetes that is not well controlled, both of them not well controlled early on in pregnancy. Gestational diabetes is different, and it doesn't really start until around 24 weeks of pregnancy. And what is happening at that point is that the placenta is starting to release particular hormones and things that create changes in the insulin sensitivity and resistance in the body, in a way to try to keep blood sugar higher for longer. And the reason is because as the baby is growing beyond this point, they need that sugar from the maternal bloodstream to pass to them so that they can chunk up. You know, they can put on the required fat that they need to be able to cope well with labour and cope well when they come out of the body. So when we have got this increased insulin resistance, some people's bodies then are not able to cope with that. And with alongside the diet that they're eating and the exercise or lack thereof that they're doing. So if you're not using up the sugar that you're eating, and then you're getting this increased insulin resistance, it can then mean that your blood sugar levels stay higher than they should do. So higher than is the right amount for the baby, higher than is the right amount for you, and then it can cause problems. And the main problem, in inverted commas, that happens is that because you've got this higher blood sugar level staying around for longer, the baby basically just slurps up more sugar. So they get more chunky. And when you've got these high blood sugar levels, what happens is that babies actually put on fat in a slightly different way to the way they would if the blood sugar levels were kind of at a normal level for a normal period of time. And they tend to get quite chunky, like around the chest and the shoulders. And this is probably the thing that most people are speaking about when they are saying that they're concerned that there's an increased risk or chance of shoulder dystocia in gestational diabetes. The thing is that increased risk only happens if your blood sugar levels are not under control. So if you are able to control your blood sugar levels, be that with changes to your diet and exercise, or be that with the use of medications like metformin or insulin, then the baby won't get extra chunky, if that makes sense. They'll just be exactly the same as people who are not having trouble with that increase in insulin resistance. Ooh, it's like a tongue twister, that.
I think this is interesting because I feel like, and I've had clients who have had type 1 diabetes, I've had clients who've developed gestational diabetes, and it seems like regardless of what type of diabetes they have, regardless of whether it's well managed or not, everyone is told they need an induction, right? Because the baby's going to be massive and they've got gestational diabetes, despite, even if the baby isn't measuring large, everyone is just told you have gestational diabetes, therefore that equals induction. And that's not really the case, is it? It's not always necessary.
No, it's definitely not necessary, and I would actually argue it is not the best course of action. And I would argue that both from my own personal opinion, but also from research studies that we have that show it. And it's for a number of reasons. So there are complications that can potentially occur when you have diabetes. And those include, because the sugar levels are high, the body doesn't cope with it so well. And so you can get, for example, more yeast infections. It's one of the signs often that makes people triggered off to think that there might be an issue. But also, when you have higher blood sugar levels, your wound healing is not as good. And so in and hold on, let me just, I've got little notes here because I've written down the exact stats to have for you. So in the wound healing is affected by so poorer in terms of healing, how time it takes to heal, in terms of there being infection, in terms of a wound separating for a C-section. So C-section wound complications happen in 18.4% of people with diabetes compared to those without diabetes, which is only 5.8%. So it's a significant difference. And that happens even if blood sugar levels are under control. So there's a process happening in the body with diabetes that means that wound healing is not as good. So that really, in my mind, is then a deterrent for choosing early cesarean section, choosing early induction, because we know that induction does increase cesarean section rates because the healing is not going to be as good. The other things that increase are also to do with injury to the body and then the consequent healing, is that perineal injury actually increases when you have diabetes. So in terms of the number of minor 1 to 2 degree tears, it's more prevalent in people who have diabetes before pregnancy and people who develop pregnancy and diabetes. Whereas second degree and larger tears, so more serious tears that require stitching and may require stitching to heal them, it's more common in pre-existing diabetes. So if people have had that blood sugar control there for longer. So again, we know that with inductions, they increase the need for instrumental delivery, and need in inverted commas because it's all kind of relative, but it is used more. So therefore, again, that's another negative for not choosing an induction early, because you are more likely to end up with perineal injury and forceps or episiotomy things. So yeah, it's not great in terms of that kind of thing. Another thing that's really important is that when you have high blood sugar levels, it actually, the fetus adapts to those changes in the maternal body, including by increasing red blood cell production. So if blood sugar levels are high, basically the oxygen transfer through the blood to the baby is not as good. So the baby will create more red blood cells to be able to cope with those changes. And this is called polycythemia. And why is this an issue? Well, when a baby is born, it means that they once they are then using their lungs to breathe, rather than having oxygen coming from that high blood sugar blood from the mother, it means that they have to break down those excess blood cells. They don't need them, and this can lead to jaundice. Yeah, and we know that jaundice is more likely in earlier babies because they're less able to process the bilirubin and things like that. So if you're having a baby early and they've got polycythemia, the likelihood of the jaundice being more severe is greater. And this, what does this mean? Their baby is more sleepy, they're less able to feed. So we have knock-on effects on feeding and having to have treatment and staying in hospital and separation and all that kind of thing. So that's another negative thing. And another adaptation and things that happens with babies, or it's not necessarily an adaptation, but when you have high blood sugar levels, it actually delays the creation of surfactant. So surfactant is a very complex molecule, and it's there that it basically helps the alveoli of the lungs when the baby is born to spring open. when the baby's in utero, those alveolar sacs are really closed in the lungs. So they do like practice breathing, but it doesn't really go into lungs. So they have amniotic fluid going a little bit in, and so they're practicing this kind of expansion and practicing using their diaphragm. But that full expansion doesn't happen until they come out and they're taking their first breaths, and we're getting that transition whilst they're still attached to the cord, hopefully, to give them that time with the oxygenated blood come from the body. But the production of this substance, this surfactant, is delayed when you have high blood sugar levels. So it means that babies that are born earlier, be that via induction of labour, be that by cesarean, their breathing is not going to be as good. They're much more likely to need respiratory assistance. Yeah, and we also know that if a baby's coming earlier in term anyway, that's already a complication. So it compounds that complication. So the baby is more likely to have breathing issues, and those breathing issues it's not just at birth. It's not just in those first few moments. We know from Hannah Darland's study in 2021 in terms of induction that the earlier gestation that an induction is happening, that babies have lifelong health complications, breathing complications. So the study only went up to 16 years, but I think we can extrapolate from that if a child has breathing issues all the way up to 16 years, that is likely to continue. Yeah. So that's another reason why it's not a great idea to have a baby early. I think really, and when people are saying, oh, your placenta's more likely to fail, that's not the case when blood sugars are controlled. It hasn't been shown to be the case with gestational diabetes, actually. So it's not true. You're not more likely to have a miscarriage just because you have a gestational diabetes label. So it's misinformation that is spread in a lot of guidance, including the NICE guidance. And you've got this recommendation that people should be offered induction of labour by 40+6. There is no evidence behind that recommendation. It's just opinion. That there's no papers that show that it improves outcomes. There's no papers that show that there's more death of babies if they are left to continue, any different to the rest of the population.
Yeah. So basically, particularly if your blood sugars are well managed, you are not higher risk than somebody who does not have gestational diabetes. Therefore, the induction is not necessary. And all of those risks that you've just spoken about are specific to somebody with diabetes or gestational diabetes. And that's not even factoring in the risks that come with induction in itself. Thinking about the fact that you are more likely to ask for opiate pain relief and the effect the opiates have on the baby and your breastfeeding.
Which includes breathing suppression. So that compounds that issue even further. Yeah,
absolutely. The fact that you are more likely to be in certain birth positions because you've possibly had an epidural or you've got CTG monitoring on, and the impact that has on the increased chances of dystocia or need for instrumental birth because you're in a suboptimal birthing position. I mean, the impact of induction is far reaching regardless of whether you have diabetes or not. So when we factor all of that in, you have to wonder why the guidelines are suggesting induction and why people are going in for those antenatal appointments and not being told all of these risks. Because I can guarantee you, people who have gestational diabetes and are going in to discuss induction are not told about the wound healing complication. In fact, that's actually the first time I've heard it. So I can guarantee there's a lot of pregnant people that are not being told that that's a factor.
Yeah, I think actually a lot of medical professionals don't know this stuff. They're very busy, and often what they do is just read the NICE guidance or have that in their mind. And it takes a bit of digging to look into what research is behind that recommendation in the NICE guidance when you realise that there actually isn't any recommendation. And really, when you kind of dive deep, it's an issue in all recommendations in all countries actually that it's incorrect. It's like a bit of a myth that kind of floats around, because it has been shown that in terms of pregnancy loss, the level for if you have no diabetes or your blood sugar levels are controlled, whatever type of diabetes you have, it's a 0.3% chance through all of pregnancy. If you have type 1 diabetes only, okay, it's 1.5%, and that's when blood sugars levels are not easily controlled. And in terms of perinatal mortality, so we're thinking about not pregnancy loss, but after that time. So for type 1 diabetes with poorly controlled blood sugars, it's 2% of babies. So 98% are fine. And that could be from any complication. It's just a kind of population data. With no diabetes, or when blood sugar levels are controlled, it's 0.4%. So it's exactly the same between the general population and someone with well-controlled blood sugars. And the risks for loss are only occurring because of issues when that organogenesis is happening in early pregnancy. And gestational diabetes does not do that. Okay, your blood sugars do not go out of control until after that organogenesis has happened. So it does not increase the chance of you miscarrying or your baby dying after birth. Yeah.
So I want to just touch on the identifying and classification of gestational diabetes, because we know that more and more people are being told they have gestational diabetes over the years, and there is a narrative that we are all getting older and we're all getting fatter, and therefore we are developing gestational diabetes because we are also unhealthy. But we know that's not strictly true, is it? When it comes to the increase in this explosion of gestational diabetes. So do you want to talk a little bit about why more people are being diagnosed with gestational diabetes?
Yeah, it's a real bugbear of mine that anytime you have a program, Panorama or a File on 4 or whatever, and you have a medic on there, the sort of white old obstetrician, it's always, well, women are getting older and fatter and more complex, and it's all their fault, this women blaming thing. But actually, the massive increase in diabetes has only happened because of an organisation which is a very long name, so I've written it down: the International Association of Diabetes and Pregnancy Group Consensus Panel. So hope you can all remember that. There'll be tests later. No, I'm joking. They got together after the HAPO study, which was in 2008, and other studies and kind of extra data that was not released or not published. And they came together in a panel and decided that they would change the levels at which gestational diabetes threshold was put in place. And I've got to give a shout out to Dr. Rachel Reed, who's done a massive deep dive on this, and it took her ages to find this information. That in 1980, the World Health Organization said if you were having a glucose tolerance test, that the fasting blood level, should be 8.0 millimoles per litre. That after 1 hour after you'd had the 75 grams of glucose, it should be 11.0, and after 2 hours after having the 75 grams of glucose drink, it should be 9.0. So that's more in line with when you would be diagnosed with diabetes outside of pregnancy. Then in the 2000s, these levels were changed for some reason. So it was changed from the fasting level from 8 to 7, and then she couldn't actually find data for the 1 hour one, but then the 2 hour one was changed from 9.0 to 7.8. So they've been reduced down. But it gets worse, because then after this great big long named committee got together, they decided that they would change the fasting level. So from 8 down to 7 down to 5.1. So a massive reduction. Okay, the 1 hour glucose from 11 down to 10, and the 2 hour glucose test from 9 down to 8.5, and in the UK it's 7.5. In most places. It's variable. Yeah, it's variable between hospitals, and often that variability is not down to research or outcomes. It's down to the fact that the hospital can't cope with more people being diagnosed with gestational diabetes. They can't offer them the extra support that they're supposed to under the guidance, and so they diagnose less people.
It makes sense. It's ridiculous.
So yeah, so it's crazy. And So it's the new diagnostic criteria that are responsible for the massive increase in gestational diabetes, not that women are getting older and fatter and more complex, because actually the age difference is very minimal. And I think there was an Australian study that studied it that actually showed that the women were thinner. There were less overweight and obese, people in in the study. So yeah, and has the change in guidelines since 2010 made outcomes better? Well, what has happened is there's been no change in birth weight of babies. With increased induction of labour, etc., there's been no change in shoulder dystocia, and there has been no change in shoulder dystocia injury. So injuries following shoulder dystocia. There has been an increase in hypertensive disorders, okay, and that's caused by medication used to control diabetes. Okay, that's not because women are getting older and fatter and more complex. It's because the medications being used to treat them are giving them complications. There's increased induction of labour, both early and at term, and we know that there are negative consequences for this. The cesarean rate lowered in the study, but the reason why it's lowering is because induction of labour is being recommended instead of cesarean. So it used to be that they would recommend cesarean, but now they will recommend induction of labour. And depressingly, in this study, they found that if you have insulin controlled gestational diabetes, your chance of having a spontaneous vaginal birth was just 8%.
Crazy.
Because of all of the coercion and the scaremongering and all that kind of thing. Yeah. And if you had a diagnosis of gestational diabetes, but you weren't using insulin to control it, you were using a diet and changing your lifestyle a bit and things like that, the chance of having a spontaneous vaginal birth was 23.6, which quite honestly feels a bit like it's in line with what it is for anybody these days, because they're so keen to induce people. I mean, a bit worse, but yeah, the induction happy crew are well and truly established.
So essentially what they've done is just move the goalposts repeatedly. And a person with type 1 diabetes would be classed as diabetic. Sorry, not classed as diabetic, and a person with gestational diabetes with the same readings will be classed as diabetic because they have shifted the goalposts during pregnancy. The other thing that I think is really interesting, talking about blood sugar levels and diet controlled and so on, is that I know people with type 1 diabetes are very, very likely to be told induction or C-section. But I would argue that somebody with type 1 diabetes is far better at managing their blood sugar levels because they've had years of doing so and really know what they're doing, compared to somebody with gestational diabetes who is completely new to diabetes and having to figure out their diet and figure out their levels and things in a very short period of time. So again, it doesn't really make sense, this whole jumping in early to get babies out when somebody is managing their blood sugars okay.
Yeah, though the guidance says it's not what is actually in reality, in that care should be individualized. So this blanket, like, you need to have an induction because you've got gestational diabetes, because you're type 1 diabetic, because you're over this age, because your fetus is over this age that we've guessed randomly and we only get right actually 4% of the time. All of these like blanket reasons are not improving outcomes. They are not making it safer. And even though there's plenty of data to show that, they're just yeah, so those of you who've seen my reels on Facebook where I like get my husband playing Dr. Patriarchy to cover his eyes and cover his ears, like la 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 la, we don't want to know what we're doing isn't helping, we don't want to know that it's making things worse, we're just going to carry on, we're going to medicalize things more, we're going to do more testing, we're going to invade people's privacy more and more and more. And it's not helping. It's worsening outcomes. It's not reducing stillbirth rates. It's increasing neonatal mortality. It's causing more deaths than not interfering.
Yeah. And we know this. I mean, I spend a long time analysing census data and updating my graph each year to show the trend in stillbirths, which is not dropping, it's just plateaued, and the massive increase in C-sections, postpartum hemorrhages, induction.
Postnatal depression.
Yeah, absolutely. The
And
increase
cost.
in prevention is not improving outcomes. Yeah, and cost.
No. Yeah.
In a cash-strapped NHS. And the thing that really frustrates me, and I've got an example of this from last Friday, because I was teaching a client and she was telling me she went into the appointment with her obstetrician, and she is highly educated, well-versed, well-read, she'd done her research, and she was questioning things, and the obstetrician was like, that's Dr. Google. That's not a thing. And then just plucked figures out of the air and made stuff up. And the only reason that she knows that this obstetrician is making things up is because she's spoken to me, and I'm like, well, that's not a thing. Like, you can't quantify that thing that they said. And actually there is evidence, and here's the research study for you to read so you can make an informed decision. So I find it hugely frustrating. I get that midwives and obstetricians are busy and they're time strapped, and they have guidelines and policies that they need to adhere to. Quite frankly, they have a duty of care to be doing that research, because it is absurd that we are leaving it to pregnant people to educate themselves and listen to podcasts like this, quite frankly, in order to understand a topic like gestational diabetes to the level where they can make an informed decision on what they want to do. Sorry, that was a big rant.
Yeah.
Cross.
No, I totally agree. You shouldn't need to have a degree to be pregnant. Your body knows what to do. Unfortunately, the people with degrees are making you feel like you don't know what's right. And their authoritative knowledge is perceived as being better than your intuitive knowledge. And actually, it's not. And every study into the safety outcomes and poor outcomes shows that when maternal instincts are ignored, that's when problems happen. So when parents are saying something's not right, please listen to me, and people are not listened to, that's when problems happen. It's mad, really. And these tighter blood glucose level controls have significantly worsened outcomes. There's been a slight increase in shoulder dystocia incidence, which is expected, because basically so many more people are having inductions. They're then having epidurals, which we know increases shoulder dystocia. The management of shoulder dystocia in institutional settings is really abysmal and causes the vast majority of injuries. It should be generally most of the time, a very simple and easy thing to resolve. And we know from the Big Baby trial that induction of labour does not improve outcomes for shoulder dystocia. And it's exactly the same with gestational diabetes. We've seen no difference statistically in the cesarean rate, in perinatal mortality with these tighter controls, whether the baby is large for gestational age, so it hasn't even made a difference to their size. And what has increased is the use of medications. And this is the thing, all of these changes are being fueled by pharmaceutical industries that make money out of telling you you're sick, giving you medications that then make you need more medications that make you sick. And so the cycle continues. It's not in their interest to have happy, healthy mothers and babies, because it doesn't make them money. And when women are given medications, because they're outside of these new made up thresholds that aren't improving outcomes, they end up with more medications, more hypertensive disorders, more composite serious maternal health outcomes, more death, more pulmonary edema, more stroke, more eclampsia and preeclampsia, more adult respiratory distress syndrome, more cardiac arrest, more placental abruption, more respiratory distress, hemolysis, coagulopathy, which is where the blood clotting disorders, major postpartum hemorrhages, deep vein thrombosis, pulmonary embolism. Again, these are blood clotting disorders, and that require anticoagulant therapy. And who makes money from that? The companies that make the anticoagulant therapy. So by adhering to these new guidelines and taking medications to try to keep yourself in these very narrow bands, you are increasing your risks of all kinds of things. And also it reduces, it can reduce the size of babies. which might tinily make a difference in terms of shoulder dystocia, but actually we haven't studied the long-term impacts of that. And what the medications do is that they actually decrease lean tissue in a baby rather than the fatty tissue when you take these medications, okay, which is probably not good for their bodies in the long term. Yeah, and we're not looking at that.
Yeah,
we're not studying that. It's the medical fear of a big baby is more dangerous than just having a big baby. And the medical fear of litigation, if there is a shoulder dystocia and they do something wrong in a panic, that is fueling a lot of this stuff. If they just understood about biomechanics and how to move a body and make space, and it would just reduce the tiny numbers that are happening anyway and the tiny numbers of injuries. You know, the big baby study was stopped because there weren't enough poor outcomes. There weren't enough bad things happening, and they realised that they would have to continue to spend millions and millions of pounds to show a very negligible difference between induction and actually the study just showed between induction and induction, didn't it? In the end, it wasn't even between induction and waiting, because 70% of the people that were waiting ended up with induction. So, you know, this, of course, there's not going to be a difference, is there?
Farce. It's a farce. The study is nonsensical. But yeah, it's that cascade of intervention that we always talk about, isn't it? And that's what's happening with this. That's what's happening with your big baby trial. You know, it's a theme throughout all of maternity care: defensive practice, and that's this cascade of intervention. You know, the induction epidemic is essentially defensive practice at the cost of physical health, mental health, breastfeeding rates, postnatal depression, physical trauma, perineal trauma. I mean, the list goes on and on and on. But we don't worry about all of that stuff because we just need to prevent the small percentage of stillbirths, which obviously we do want to prevent. But let's be honest, you're never going to get that down to zero, because unfortunately some babies do pass, and there is nothing that you could have done to prevent that. That is life and death, right? But we have this culture where we are, or medical culture where we are looking at that worst outcome and just throwing everything at the pregnancy and the birth at all costs, at the expense of everything else. And I think that's why talking about, you know, gestational diabetes, for example, and those moving goalposts is really, really important, so that people can make those informed decisions about whether they want to go ahead with the induction or the C-section that they're being offered, or they do feel comfortable looking at the stats to watch and wait. And just to say that is, you know, a really important point to make, that ultimately it is your choice. You know, as a pregnant person, it is your choice. You may be being told you have to, I'm doing air quotes here, have to have an induction, but you don't have to. No one's going to turn up at your house and drag you to hospital. You know, you decide whether you want that induction or not. I mean, they may not cancel it very easily, but if they want to waste their NHS time with leaving that booking in, that's their problem. But you don't have to have an induction or a C-section or any kind of intervention if you do not feel it's necessary. It is you have autonomy over yourself and your baby.
Big old rant we've had. Yeah, it's true. And
is there anything else that you wanted to raise before we finish today's episode? Because I know you had in mind some different areas that we wanted to make sure we covered. Have we missed anything around?
Yeah, I mean, I think it's important to sort of say that, you know, in studies, so in the British Journal of Obstetrics and Gynecology in 2019, there was a study by Stacey et al. And so looking at gestational diabetes and the risk of late stillbirth, it was a case control study. And there was no difference, even with abnormal blood glucose levels. There was no increase in stillbirth. So I think that's just a really important point, that when you look at the evidence, there is no increased risk of stillbirth. So if anyone is telling you that there is, that just on you having gestational diabetes, that's not true. Okay, if there are other complications going on, it's important to understand what the chances are with that complication. Okay, because often things are piled up, and so well, you've got this risk factor. You're over 40. Your BMI is too high. You've got gestational diabetes. This risk is massive that your baby's going to die. It's like, okay, so what are those individual risks when I look at them? So we know that age makes less of a difference than gestational week. Gestational week, whatever week of gestation you are, makes less of a difference than a percent. Less than a difference than 0.1%, isn't it, in terms of your risk? Okay, and now we know that having gestational diabetes, whether your blood sugar levels are controlled or not, makes no difference to your risk. So maybe 0.1% of a risk of something is enough for you to think, I want to take the risk of all of the risks of induction or all the risks of cesarean. Okay, but maybe it doesn't. And if your healthcare provider is pressuring you and using coercive language, it is against their code of conduct. And I really urge you to record appointments. Say, I'm going to record this appointment. You can say, use an excuse that I've just got pregnancy brain. I'm not going to remember things. We know from studies that people barely retain half of the information. I think it's 30% or something of information. I can't remember the exact figure when you're in an appointment. So it's perfectly valid to record an appointment so you can listen back to it in order to make an informed choice for you. Yeah, and it's perfectly legal for you to record your conversations with your doctor. Okay, and if you say that, it can cut down the amount of coercion. But it's completely unacceptable. And even though complaints don't tend to make much of a difference in my experience, I've supported a lot of people over the years through complaints, I really would urge people to make a complaint and say, this person has breached this part of the NMC code or this part of the GNC code. Make a complaint to the General Medical Council, make a complaint to the Nursing and Midwifery Council, make a complaint to PALS at the hospital. Okay, because if we don't complain, they're going to keep treating us badly. We need to create enough of a noise and enough of an inconvenience, like many buzzing mosquitoes, because otherwise they're just going to keep doing it, and it's not okay. It's not okay. The number of people that we know are coming out with feeling traumatized because they feel like they've been forced, feel like they have to. If I had a pound for every time someone said, well, I have to do this, I didn't want to do it, but I was told I have to, I'd be a very rich woman, a very sad, very rich woman. As it is, I'm just very sad. Because it shouldn't be happening. It shouldn't be happening. And the thing is, it doesn't prevent litigation. Because if people feel forced into something and then that something goes wrong, which inevitably does, people end up feeling more angry than if somebody said, look, here are the risks this way. Here are the risks this way. What do you need more information? What would you like to do? I'm going to support you with your decision. If at any point you want to change your mind, that's fine. We'll sort it out. You feel so much better, like even if everything went disastrously wrong, if someone was with you and helping you, than if someone's gone, you have to do this. Your baby's going to die if you don't do this. I know better than you.
Yeah.
You need to listen to me. Yeah. It's just absolute madness. So yeah, in terms of other things, after we've ranted, that can be helpful. I think the thing to understand about gestational diabetes is it is a sign in your body that your body is not coping well with what you are fueling your body with. Okay, so some of us are better able to process carbohydrates than others, and there are quite significant differences between different races as well. We see that with the chances of getting gestational diabetes being higher in different populations. So it's really that whatever is happening in our system, in our gut microflora, in things that we don't yet fully understand, it means that our bodies just don't work well on high carbohydrate diets, and that they would work better on a higher protein, higher fat diet, much more like a kind of hunter-gatherer diet, where the diet's being based much more on that than it is on grains and sugars. And so it's really an early warning signal. If you get gestational diabetes in pregnancy, it is a very strong indicator that you are going to go on to develop type 2 diabetes. In some studies, it's as high as 70% of people who have gestational diabetes go on to develop type 2 diabetes. So it's really your body saying, I'm not coping well with how you are eating. It doesn't work for me. I'm really struggling. I've got this extra stress of a baby growing in here that I'm trying to feed. I'm not coping well with it. So it's an alarm bell for your body saying, this is not good. And we know that having type 2 diabetes is like linked in with all kinds of other disorders like heart diseases and cancers and all kinds of things. So if you can fuel your body in a better way and use your body in a way that works for your body, you will have greater lifelong health. And it's not just you when you're pregnant. What you put into your body when you're pregnant is helping to build your baby. Okay, your baby will take stuff from you if they're not getting the nutrition from what you're eating. I mean, that happened to me. I had hyperemesis through my whole pregnancy. One of my patients used to joke that Seb was my buttock baby, because as the pregnancy went on, my buttocks got smaller. Unfortunately, they got bigger again. But yeah, he was made entirely out of bottom. So I was a stone lighter when I was fully pregnant than I was when I started. So the baby will take what it needs from your body, but what do you want your baby to be made out of is kind of what I'm saying. Do you want them to be made out of cans of Coke and sweets and things like that, or do you want the building blocks for their cells, for their lifelong health, to be made out of whole foods, good sources of protein, good fats? Because if you find you struggle to eat those kind of healthy things for you, sometimes it can help in pregnancy to kickstart a healthier way of being. And there are lots of simple different things that you can do to help your blood sugars be in a more healthy level. And I have talked about them in great detail in my gestational diabetes lecture. And it comes with a PDF that has meal plans, it has recipe ideas, and it's also got information about helpful supplements, because it's very boring to listen to what supplements are on a podcast. So I put it all in a PDF and it's all in the lecture. And I wanted to offer your listeners a 50% off deal for getting hold of my gestational diabetes lecture and PDF, and you can use the code Serenity50, so Serenity50, all lowercase, and maybe we can put a link in the show notes, but people can also find it on my website or from my Instagram. I'll post on Instagram when this goes live for people to find it as well. And it's basically a 2-hour lecture talking about gestational diabetes, covering different types and what the risks are and shoulder dystocia and all that kind of thing, and then also about all of the nutrition stuff that you can do and the lifestyle stuff that you can do to make a difference. And something as simple as, after you eat, doing the vacuuming for 10 minutes can help to reduce blood sugar spikes, using your body. Or how we spoke earlier about how the glucose goes into muscles and goes into the liver. Well, if after dinner you actually just flex and point your toes, like the ballet teachers used to say, good toes, naughty toes, good toes, naughty toes. If you do that, it's working the muscles in your calf, and there's a muscle deep in your calf called the soleus, which actually has the highest concentration of glucose storage of muscles in the body. And it's there so that your calf muscle can be springy, so you can run away from something scary. But it means that if after dinner you're just doing this with your feet for 5 minutes, so you don't even have to get up and dance to music, you don't have to do the vacuuming or clean the windows if you don't want to, you can literally sit and watch Netflix and just do this with your feet, and that will help to reduce the blood sugar spike in your body. So the lecture and the PDF are filled with lots of little tips like that to help you to control it without the need for medication, because obviously medications have side effects. They have side effects for you and they have side effects for your baby, and we don't really understand the long-term implications of those, but we do know that there are certain short-term implications that happen. And again, I talk a bit more about those in the lecture because it's quite complex to go into now, but just in case it's useful for anybody.
Thank you, Shellie. I'll make sure that we put both a link to your lecture and the discount code in the show notes, as well as the research studies that you've mentioned as well, just in case anybody wants to go and have a read of those as well. But thank you so much for your time today. It's been fascinating and informative, and like I said, cathartic to have a bit of a rant. I feel like all of my episodes are quite ranty. And I definitely will have you on again because I love chatting to you. And I urge anybody who is not following Shellie, the Serenity Doula, on Instagram already, to go and follow her, because her reels are they are the best. They are hilarious, but also very triggering for healthcare professionals, and very informative, right? So go and follow Shellie if you don't follow already. But thank you so much for your time today, Shellie.
Oh, thanks very much for having me, Erin. It's been lovely to chat with you, as always.
Thank you.